Fine. Thank you, Stephen. Before I forget, I just wanted to thank the industry, the ABC of Urogynaecology, Dallas, Boston, and Coloplast that support us in this event. And without whose help, we couldn't have done it. So thank you. My talk will go around overactive bladder and slings. I think it's a big dilemma we all have faced. Like, do slings help? Do they make it worse? Do they cause it? And how we go around that, and how we select our patients, or whose patient will get the most of a sling in a picture of mixed urinary incontinence. So, if we look at the definition from a UGICS terminology document, stress urinary incontinence is a complaint of loss of urine in effort or physical exertion, sneezing or coughing. Urgency urinary incontinence is a complaint of loss of urine with urgency, and mixed incontinence would be a combination of both, either or, usually both together. And overactive bladder, it's urinary urgency with frequency, nocturia, and it can be with or without incontinence. Why is that important? Because overactive bladder is known to have a direct impact on quality of life. It causes anxiety, depression, isolation. It affects the general perception of your well-being. People that have to go to the toilet all the time have this constant sense of urgency. They do much worse than people with stress incontinence, where people can predict when the leak's going to happen. We know the risk factors for overactive bladder: age, menopause, high BMI, smoking, and we know that it's also associated with prolapse and pre-existing stress incontinence. So what I found out is that actually mixed incontinence is much more common than what we think. Even the hardcore patients where we ask them to cough, they leak, and we think that's stress. They all have some degree of urgency, and we always have to be aware that patients may not be as easy to identify as we think. So if we look at this study from Sweden, randomized controlled trial, 267 patients, and they asked patients, apart from the stress component, all the urgency. So what's interesting is that inclusion criteria was history of stress incontinence, indication for surgical treatment, so they were meant to have a sling. They had a positive cough stress test, and the Trueta instability score was 7 or less. So the DIS is a questionnaire, 10 items, and you can score up to 20. And that gives you a degree of if it's whether pure stress or more urgency. So less than 7, it's supposed to be pure stress. But then on the other questionnaire, when you ask them about frequency, about 75% said that they had some degree of urgency, and 66% had leaks with urgency. 75% have frequency, 66 leaks with urgency. And these patients that they come and they leak with 50 mils of residual. So, clearly pure stress incontinence patients, and they still have some mixed symptoms and some urgency and frequency. What we saw in those patients is that after a sling, all these symptoms, the urgency and the frequency improved. Whether that is because a patient that leaks with every cough tends to go more often to empty the bladder and tends to develop a sense of urgency. So when the bladder is half full, he feels that, I need to go and empty it now, because otherwise, next time I cough, that's it, I have an accident. So whether that changes that behavior, or it's clearly a treatment for the bladder mechanism, that's still to decide. Another interesting thing is that about 5% developed de novo urgency, and that was only after 3 years. So the first year they were fine, and gradually more and more developed some sort of de novo urgency. And that's pure stress incontinence patients. So it's clearly something that we're going to face. And I just thought we'll go through the literature and see, what's best and which patients will respond best to the treatment. So again, I think we need to understand what's mixed urinary incontinence. Some people postulate that it's a severe form of stress incontinence, so intrinsic sphincter deficiency rather than two separate mechanisms. So it's all together. And so what they say it happens is with ISD you have a weak sphincter. So in any exertion you have some funneling, and that will expose an area of the urethra that's very sensitive. So when urine will hit that spot, will trigger a contraction of the detrusor, and that will cause detrusor overactivity. It won't be of how to say it, a mix of signals to the detrusor, but it will be more like an anatomical change. So we know that in all the patients we see with stress or mixed incontinence, generally we try conservative measures, but those who have a substantial degree of urgency and they have a stress incontinence that's bothering them enough that they would seek surgical treatment, then what do we do? Because we know that some of the slings, although some of them can help with the continence, we don't want to cause another problem that may be even more difficult to manage. So since we introduced the mid-urethral slings, then there's always been this concern that are we causing another problem that maybe in the long term will be, even more deleterious than the stress incontinence. So should we put a sling? Shouldn't we? Which patients? One of the theories why a sling can help in these patients is because you may be able to close that sort of weak sphincter more in the mid-urethra, and that will avoid all this urine stimulating that area of the urethra. So what do we do? I looked at different papers and tried to get some conclusions and some help on how to go about the decision making. So this is a secondary analysis of 3 randomized controlled trials from the States. So one trial was looking at urodynamics before stress incontinence patients, whether that was useful or not. We had another trial looking at bridge and fascial sling. And the Thomas trial looked at retropubic versus transobturator. So the first analysis would be obviously to success rates. Primary outcome would be, can I treat the stress incontinence? On the secondary analysis, they look at some degree of overactive blood and how they behave over time. Again, that's another difficult thing about overactive blood and urgency is that it's very subjective. So we don't have an objective measure tool to assess what's the degree of urgency or frequency other than questionnaires. And that's always very based on patients' perception. So all these patients had questionnaires, and they all scored very high when they asked them if they had some degree of bother associated with urgency and frequency. So we could say that they were all mixed incontinence patients. What they found is that to put sling on patients where the stress incontinence predominant, but they have some degree of urgency, a mid-urethral sling can help. But although it will help with the stress incontinence, that improvement of the urgency will decline over time. We won't see it straight away, but it'll decline over time. So we see we see it's about 5 years, and although it increasingly had an improvement, then gradually declined, and that's in urgency, not in stress. Also in the top table, so we see how the scoring for the urgency sort of declines over time, but not the stress in those cases. So again, another long-term results on stress incontinence. So this is a retrospective study where they look at patients who had a sling and over time how they evolve. So what they found is that although initially they improve their urgency and their frequency, over time that benefit sort of decline. in this case, in this study, they excluded all the patients who developed de novo urgency earlier on. So it's all patients that had stress incontinence and some with mixed incontinence, and how they go over time. So the cure rate at 6 to 8 years was very high for stress incontinence, but it declined. It went down to 30% for the mixed symptoms. Again, so another retrospective study looking at PVT versus Monarch, so transurethral and trans retropubic sling questionnaire, 1,000 patients, 1,200 patients, and we got 534 that completed both baseline and follow-up. So they looked at them up to 3 years after the operation. So in this study, what they found is that patients with mixed incontinence, that initially they had mixed incontinence, they were more complicated. They were older, they had more comorbidities, they had worse incontinence, worse scores overall. So I think we shouldn't forget that probably the outcomes are related, that it's to start with the more difficult patients. And what they found is that in these patients, who the higher the degree of urgency and frequency, the higher the failure rate of the stress incontinence procedure. So the mid-urethral sling was not as effective if the patients had a baseline score higher in all the urgency parameters. The other thing is that they reported less global improvement. So, because they have two problems, even if you solve one, they still have one left. So it's patients that are generally more unhappy, even if you do your best, even if you say, look, but now you don't leak when you cough. Yeah, but still have to go, 10 times a day. I still have this, I still have that. So we need to be very mindful that, they can be complicated patients, and we need to be very careful on what to offer and how to manage expectations, I would say. Because here, even though they say they were unhappy, when they looked at objective measures, and they looked at the questionnaires, they were actually better. So what they saw is that another interesting thing, one of the questionnaires, the Meza Questionnaire, it has two subsets. One is for stress, one is for urgency. The ones who had higher Meza urge score, so more than 10 points, they were more likely to fail on their stress incontinence procedure. So the worse the urgency, the worse the frequency, the higher that the sling would not be as effective or as useful. So those are patients that have symptoms, subjective, based on a questionnaire. So how about people that have the truth overactivity on urodynamics, like they have proper DO with contractions? How do they do? Should we put a sling on them? So this is again a retrospective study from the UK, where they compared 100 patients with pure stress with 100 patients with stress and DO, and they looked at 6 years follow-up. So again, the ones who were score higher were mainly stress incontinence. They were more likely to be satisfied with the results. They were more likely to be happy with the outcome of the surgery. And in the group with DO, we had 65% got better, but then 30 were unchanged, and we got about 17% that at 6 years they were worse. And not only that, those patients had more difficult to manage overactive bladder urgency, so they even more unhappy. And the symptoms for that group were more likely to be graded as severe. Although again, when we look at globally quality of life, they were both better. But still, we had a cohort of patients that really worsened their symptoms. Then what are the risk factors in patients with mixed incontinence for persistence of symptoms? What makes it more likely that you're going to keep that you be one of, part of this 30% or maybe of those 15%. So study from Anna's group in Australia and Joe, they look at what are the risk factors for patients with the true overactivity or urge urinary incontinence for have persistence of their symptoms. So they looked at 754 consecutive women with stress incontinence and urgency, and then 514 with stress incontinence and urgency urinary incontinence. So either just symptom or incontinence. Both had mixed symptoms. So what happened is, so what they found is that, again, the worse the symptoms prior to the surgery, the more likely that the urgency and the urgency incontinence will remain after the surgery. So if they had DO on urodynamics, if they had intrinsic sphincter deficiency, so on urodynamics parameter, if they measure the maximal urethral closure pressure, if that was very low, then they're more likely to have urgency and urgency incontinence. What they found as well is that concomitant surgery to correct the prolapse would be protective. So if you're gonna do a sling and correction of the prolapse at the same time, those patients would do better in terms of urgency. And they found no difference between the type of sling, whether retropubic or transobturator. Again, another study looking at predictors for persistent detrusor overactivity. In this study, I found it interesting because they've used 4 types of slings. One of them is a bladder neck sling. So basically, it's like a vaginal birch. So you use scapula to anchor your sling onto the Cooper's ligament, and you just put it into the bladder neck. Because the principle was, okay, if there's funneling and is a problem on the bladder neck, then maybe we'll correct that, and that may be, the solution. Actually, that made it worse. And we've seen that with normal retropubic and transobturator slings. When they're not in the mid-urethra, in the bladder neck, the urgency is way higher, and also the failure rates. So here we see that it's nearly 7 times more likely to have persistent DO with the bladder neck sling. TVT 2 and transobturator 1. And again, this what they looked at urodynamic parameters as well, before and after, and they found the same. They found that ISD, low closure pressures, if the volume of the bladder was lower, so a small bladder capacity was more likely to result in a persistence of the detrusor overactivity or mixed symptoms. And then, so we looked at people with mixed incontinence and people with detrusor overactivity. So what about de novo? What about those ones who have no symptoms at all and develop after a sling mixed incontinence or urgent incontinence? So this is a systematic review by Stelios. He reviewed 32 studies and a total of 3,000 patients. One of the things he says is that it was very difficult to assess which patients were suitable for inclusion in the systematic review because of the terminology and the subjectivity of the urgency. So some people call it urgency, some people call it frequency with urgency, some people call it urge with frequency, some people call it detrusor instability, detrusor overactivity. Whether that's it was very difficult to keep it clean in a sense. So what they found that after excluding all the studies who enrolled patients with mixed symptoms, so purely studies with stress incontinence patients, the overall incidence was about 9-10%. It was pretty much the same all around with all the different slings. So again, another study from Australia. So what are the risk factors for patients to develop de novo urgency urinary incontinence after sling? So they looked at 358 patients, compare with 598, and then they looked at which ones were more likely to develop de novo as opposed to just persistence. Again, same things. It's always the same risk factors. So ISD odds ratio of nearly 4, so nearly 4 times more likely to develop either de novo or persistence if you have low closure pressures or something that suggests sphincter deficiency. If you had previous sling or previous prolapse surgery, you were more likely to develop it. Again, we're talking about very complicated patients who had failed surgery already. So we can assume that the outcome won't be as good as a patient who's virgin. And then if they had, again, detrusor overactivity confirmed on urodynamics, if you could see that the contractions of the detrusor, that was more likely to cause persistence of symptoms. And again, protective would be surgery, correcting the prolapse apical or anterior wall prolapse. And again, no difference between type of sling. So in terms of predicting the outcome, which patients will benefit most? I think what I've found is that if the stress symptoms predate the mixed symptoms, then surgery may relieve the symptoms of the urgency. And if we do urodynamics, parameters that can help us predict which patients will do better and which patients won't do as well would be the maximal urethral closure pressure. So if that's low, if that's suggestive of intrinsic sphincter deficiency, those patients will tend to do worse. Will tend to do worse, obviously. We know already that they'll do worse with the stress component, but they may do worse if they have mix, or they may be more likely to develop de novo. Also, if they have low flow rate, low capacity, and we see contractions in the detrusor. Also, low pressures at a low volume at DO, so you don't need to fill the bladder too much to get a contraction. That means quite severe detrusor overactivity, so that means worse outcome. And again, depending, if the pressure of the detrusor contraction is higher, again, worse outcome. So in summary, I think mixed incontinence is more common than we think. I think even the patients who we believe they're pure stress incontinence, they all have some degree of frequency and urgency. And again, whether that's behavioral or whether that's physical, that's anatomical, we still have to be aware of the possibility that they may have persistence, they may be part of that 30% that have persistence mixed symptoms, or even the 15% who just get worse and develop de novo. But also, it's known that patients with mild urgency symptoms, the ones I would say pure stress, if we can select them properly, I think 50% of them, they can get better. So that's a good, 1 out of every 2 will get better of one part that we're not aiming specifically to treat, but they will get better as well. So they'll get probably 90% better from the stress component and 50% better of the urgency. So I think that's good. And and just be mindful of all the signs who may make you identify patients where probably a sling is not just more likely to fail, or it's not just more likely to be less effective, but the patient itself is more likely to not to be happy, not to be not to see that whatever she came to you for, you didn't treat it, you didn't make it better, you made it worse. So that's it. Thank you very much.